The final lab today, and for lecture as well, is the urinary system. So now we're talking about the kidney. And there's two kidneys, right? There's a left kidney and a right kidney. The right kidney is slightly lower than the left kidney because the liver takes up a lot of space below the diaphragm. And the kidneys are what's called retroperitoneal. Which means they're behind the abdominal contents, like almost embedded in the muscular wall of your back. Right? They call that retroperitoneal, or towards the back, and they're anchored right in that muscle. So we'll see that. Now, the functions of the kidneys and the urinary system, one of the main functions is all the blood that comes out of your heart, right? Every bit of your cardiac output, 5 liters, goes to the kidneys to be filtered. So filtration is filtering blood. And that's blood. It's filtering every bit of the blood. So we'll see how that works. And now, not everything that's filtered out is going to go into the urine, right? It becomes filtrate. Right? You hear the term filtrate. It's still in the kidney, right? It's still in the kidney. And the second function is absorption or reabsorption. So this is going back into the blood. So the filtrate or the filtration creates filtrate. Some of the filtrate, most of the filtrate, is going to be reabsorbed back to blood. That's an important concept, because there's no better place than the kidney, showing you the different fluid compartments between the cells, the lumens of the tubules, the extracellular fluid, and the blood. And I'll show you that. The third thing is, now this is the kidney, so this is called secretion. Now secretion is more like excretion from the kidney. So that's going to go out of the body and become urine. So whatever is excreted is your urine. Now the kidneys also secrete hormones as well. So there is endocrine function, which you're going to find out in lecture. And last, but of course not least, is your acid-base balance. So endocrine hormones, right? Secreting hormones, endocrine. So the pH of the blood, remember the pH of the blood should be slightly alkaline, 7.4 pH of blood. So between, like you just learned, the respiratory system and lymphatic, but mostly the respiratory system, the lungs and the kidney work together to maintain this acid balance base. Acid base balance. And if it's above 7.4, the pH of blood, that's alkalosis. If it's below 7.4, it's acidosis. But the kidneys and the lungs, the urinary system and the respiratory system, work together to maintain a range, a compensatory range of 7.35 to 7.45. So that's just a compensatory range, which is acceptable, but really this is where you want the blood to be at as far as pH. Now the functional cell of the urinary system, of the kidney, is called the nephron. So we'll learn all about the nephron and its parts. So the nephron does filtration. The nephron does reabsorption, secretion, and helps out with acid-base balance. Okay, so remember, acid-base has to do with either too much hydrogen is acid, hydrogen ion, bicarbonate ion is base. So your kidney is going to do a job with either reabsorbing hydrogen, bicarbonate ion, this is the bicarbonate ion, or excreting or secreting either one of these to maintain that acid-base balance. So all the blood goes into the kidneys. And these are the parts of the kidney. I like these tables, of course. You go through and you see what the DCT, I always start here. Now let's see. Yeah, I would start here. This is the beginning, get used to the terms called the glomerulus and the glomerular capsule. Now together, they're going to be the renal corpuscle. And filtration happens at the glomerulus or the renal corpuscle. Then the proximal convoluted tubule, or PCT, and this is where I would say 65% of the solutes that come out of the filtration will be reabsorbed at the PCT. So that's really important. Then you have the nephron loop, which is also called the loop of Henle. It's also about reabsorption and some secretion. So there's a descending loop, two sides. There's an ascending loop. It's a kind of a hairpin turn. So the glomerulus is capillaries, all capillaries. Then it has a capsule and a space. And then the PCT is here. And then it loops down into a very long loop of Henle and then comes back up into the, and you have the DCT up in here. And then it filters out into a collecting duct, which you'll see. So these are all the parts. Just get to know the names and we'll look at them later. Okay, this is a general gross anatomy of a kidney. Let's say this is the left kidney. So blood is coming in via the renal artery, which you remember from the beginning of the semester. And blood will go into the kidney, deeper into the kidney and branch. And the next branch of arteries is called the segmental arteries, just to get you started on the blood flow. And that'll continue. It doesn't show you on this picture. So, of course, this is the deoxygenated blood coming out. This is the renal vein, going back to the inferior vena cava. Okay, so there's a couple of gross anatomy parts that are real simple. The outer part is just a capsule. It's called the renal capsule. And that's not so important as far as physiology of the nephron. There's no nephrons in the renal capsule. That's just a dense, irregular connective tissue that basically holds this renal gland, the kidney, in place. Together, it's like the skin of a tomato or the skin of a grape. All right, but if you notice, there's an outer portion. And if you remember, the outer portion is called cortex, which means bark, right? So this is the renal cortex. So remember, the renal cortex is important. I'll tell you why. Because this is where the glomerulus is, or the renal corpuscle. And these nephrons, by the way, which is this is the first part of the nephron. The nephrons are microscopic. There's 1 million or more nephrons in one kidney. So you can't see those, right? They're all spread out. The glomerulus is all spread out throughout the cortex. So the glomerulus is in the cortex. So really, it's hard to see here, but there is glomeruli in this cortex. So the inner part, anything that's not the cortex, is called medulla. And part of the medulla is these renal pyramids. And you can see they look like upside down pyramids. So this in here is called the renal pyramid. And this is where your loops of Henle are going to be. So the glomerulus, renal corpuscle, is in the cortex. The loops of Henle are in the medulla, specifically in the pyramids. In between the pyramids, you have like these columns, and that's really what they are. They're called renal columns. It's a good area for blood vessels to come in. You can see some blood vessels here. It doesn't show you every one of them, though. And we're going to go through the parts of the nephron. We're going to go through the parts of the pyramid leading to urine. Okay, so now let me go backwards, right? Let me go backwards. I'm going to try doing it this way. The outermost portion of where your urine is excreted is called your urethra. Like the male has a longer urethra, and it's shared with the reproductive system. The female's is shorter. Above the urethra is your urinary bladder. So you only have one bladder, you only have one urethra. But each kidney has a conduit, a tube going to the bladder, and that's the ureter. So this is all urine. This is not going to be reabsorbed. Nothing's going back into the blood at this point, of course. But then you go up top, you have this pool in here of urine, and that's called the renal pelvis. So of course that's not going to be urine either. I mean, that's not going to be reabsorbed either. And then if you look, this large area, which is kind of filled with urine as well, coming out from the nephron, this is called the major calyx. And that's urine. And then if you see, like at the bottom of each pyramid, you have another little pool of urine, and that's called the minor calyx. So you're going to have to know the blood supply in and out, starting with the renal artery, ending with the renal vein. The renal artery gets its blood, of course, from the abdominal aorta, descending aorta, and the renal vein delivers blood back, drains blood back to the inferior vena cava, which goes to the right atrium. So there's a lot of, not a lot, there's a few more. After the segmental artery, you have a few more branches going all the way to the glomerulus, and then you have a branch coming back to the renal vein. So know the difference between the cortex and the medulla, which is all about filtration, absorption, and then secretion and acid-base balance. Now, starting at the minor calyx, that's where nothing's going to be reabsorbed. It's urine now. It's on its way out into the public sewer system. So the flow of urine is minor calyx to the major calyx, which is just passageways, to the renal pelvis, ureter, urinary bladder, and urethra, and into the public sewer system outside. And here's some histology. Now, again, I told you the renal corpuscles are in the cortex. That's the glomerulus and the glomerular capsule, which is called Bowman's capsule, you'll see. So the loops are in the medulla, in the pyramids. And there are some nephrons in the columns, but for now, the columns are connective tissue as well, and they house blood vessels. So this is a good view of the nephron. Now, of course, remember, this is microscopic. This cartoon is just blowing everything up. So you can see the nephron. So we're looking at nephrons now. The functional cell, the parenchyma of the kidney, of the urinary system, the nephron. Now, there's different types of nephrons you're going to learn. There's a cortical nephron, which really doesn't have a long loop of Henle. It's got a short loop. So this is actually the most abundant of the nephrons for filtering blood and bringing things back into the blood. Back into the blood is reabsorption. But most, the one we study the most is the juxtamedullary, which means that you have the renal corpuscle in the cortex, but you have a long loop of Henle, or ascending, or a nephron loop, whatever you want to call it. Okay, so notice this is the renal corpuscle, and the glomerulus is the capillaries. Glomerulus is just capillaries. They're blood vessels. So they call them glomerular capillaries. But it's surrounded by a capsule called the glomerular capsule, or Bowman's, B-O-W-A-M-A-N, Bowman's capsule. So whatever comes out of the blood vessels, the glomerulus, goes into a space that's between Bowman's capsule, which is parietal, and the glomerulus, which is visceral. So Bowman's space contains filtrate. And it can be called the glomerular space as well. And there's filtrate in there, whatever comes out of the blood. Filtered out, right? Because we're filtering in the glomerulus, in the cortex. Here's the renal corpuscle. And we'll see more of that. So how does the blood get into the renal corpuscle? Now we're going to see the blood supply, like right here. This artery on the top of the pyramid is called the arcuate artery. Then above into the cortex, that branches further into what's called the cortical radiate. Makes sense, cortical radiate artery. Now, it's hard to see here, but there's an artery bringing blood into the glomerular capillaries via the cortical radiate artery. And that's called, this is really important, it's called the afferent arteriole. So this is probably the most important of all the blood vessel branching, because this is bringing blood right into the glomerular capillaries, into the glomerulus, into the renal corpuscle, which is surrounded by a capsule, which is called the glomerular capsule or Bowman's capsule. And the space between the glomerulus and the Bowman's capsule is called Bowman's space or glomerular space, and that's where filtrate is. And then, right now, filtrate will continue into the PCT, which is all of this right here. These are the tubules, proximal convoluted tubules. And this has a lumen and has simple cuboidal cells. So the PCT, proximal convoluted tubule, is where 65% of everything is going to be reabsorbed. Then there's a descending limb of Henle, going deep into the medulla, and it has a hairpin turn, comes back up to the ascending. And the ascending has a thick loop, thick portion, and a thin portion in the ascending. And then it winds up in the DCT, which is the distal convoluted tubule. And then the distal convoluted tubule will dump into a large vessel called collecting duct or collecting tubule. And then it'll go down into the bottom of the pyramid, and there's a papillary duct at the end of the collecting duct. Then you have the renal papilla. So the renal papilla is basically right here. And those papillary ducts are going through there. And that is urine. Now, once it gets past the papilla, the renal papilla, then you have urine. No more reabsorption. This is a histology of a renal corpuscle. So again, you're going to see this in lecture. I'll talk about these parts physiologically in lecture. So this is very important. This whole conglomeration in here is the glomerulus. And it has a membrane called the visceral layer. Visceral means the organ or body. So the glomerular capillaries, also known as the glomerulus, are capillaries, and they're fenestrated, which means they're porous because their job is filtration, right? Simple squamous epithelium that you remember diffusion and respiratory system, but now it's simple squamous epithelium in the glomerulus, and endothelial cells are for filtration. This is filtration now. And here is the capsular space or Bowman space where the filtrate will go. All right. And that has a membrane, which is parietal. Parietal is always away from the organ. So in between the parietal layer of the glomerular or Bowman's capsule and the glomerulus is the capsular space or Bowman's space, and that's filtrate. Now here's where the blood comes in. Here's where the blood comes in. This is blood coming in. Blood vessel. It doesn't show blood in there, but this is a branch off the cortical radiate artery to the afferent arteriole, delivering blood into the glomerular capillaries. So whatever is not filtrated out will go into the PCT, which is not really shown here. I can't tell if this is the PCT. I don't think it's the PCT. But right next to the glomerulus is the DCT coming up out of the medulla into the cortex. And you're going to learn about a section of the DCT called the macula densa. This is important because the kidney is really involved in blood pressure and blood volume and how much sodium is in your blood. Because remember, water follows sodium. So the macula densa is very sensitive to blood flow, concentration of sodium, and the amount of water that's in your blood. So there's a message between the DCT, macula densa, and the afferent arteriole. And there's cells in the afferent arteriole called granular cells that are going to produce a hormone, an enzymatic hormone called renin. So renin is a hormone generally, and it's released from the kidneys. Therefore, that's the endocrine function of the kidney, to release renin. And there's going to be an area called the juxtaglomerular apparatus. Just to give you a little heads up where you're going in lab lecture. And this is very sensitive to low blood pressure or change in blood pressure or sodium levels between the macula densa and the afferent arterial granular cells. So if the blood pressure is low or the blood volume is low or the sodium levels are low, renin will be released to ultimately cause vasoconstriction, and increase blood pressure. Now you're going to learn, in endocrine you might have done this in AP1 actually, AP1 that is, where you learn about angiotensin 1, angiotensin 2, and aldosterone, which have to do with increasing sodium reabsorption in the kidney and increasing blood pressure. So again, know the parts though, which is pretty straightforward. Once you see this a few times, you'll know that this is the glomerulus, this is the renal corpuscle. But thick cuboidal cells here is the DCT macula densa. And you'll see the animation, which shows the urine production and blood flow. So now you can see the PCT in here. So again, I'm not 100% sure, but looking at this looks like the PCT right here. And the PCT is all about reabsorption. So the PCT has a brush border of microvilli because that's about absorption. Increases surface area for absorption. Right? Remember, cilia is for movement. Microvilli is for absorption. In this case, we're reabsorbing. And remember, 65% of everything that's filtered out of the glomerulus will be reabsorbed in the PCT, proximal convoluted tubule. Distal convoluted tubule, things have been reabsorbed already. So this is where the macula densa is before you go to the collecting duct. Okay, so here's the question now. This is very important. What stays in the blood? What are two things that really never leave the blood vessels? So what is not filtered ever? Anybody know? Like what has to stay in the blood vessels?
Hemoglobin?
Yeah, the red blood cells that have hemoglobin. Excellent. The erythrocytes. Thank you. Red blood cells should never come out. They should never go into the filtrate, never go into Bowman's or glomerular space. Excellent. You don't want red blood cells in your urine. The next thing that should never be filtered out of the blood are plasma proteins. Like albumin, because that maintains your osmotic balance between the blood and the extracellular fluid, preventing edema and keeping good osmotic pressure. So these are never filtered out. And if they are, you see this in the urinalysis, then we have a problem. This should not be in your urine. This should always stay in the blood. Now, what's reabsorbed from the filtrate? This is your glucose. Should never stay in the urine. That should be reabsorbed in the PCT. Your amino acids, some water. Water is absorbed later on, and sodium, right? Chloride, hydrogen, bicarbonate ion, right? And other solutes. So these are the solutes, the 65% of everything that's going to be reabsorbed through the microvilli back into the PCT cells and then back into the blood. So whatever remains in the PCT lumen is going to be still filtrate, but also has a chance to be reabsorbed in the loop of Henle, or the nephron loop. So this is showing different histology. Let's see what we got here. Now this has to be the medulla on this side, the renal medulla, longitudinal section. And it really doesn't tell you that here, but this is the medulla because there's no glomerulus. There's no glomerulus here either. These are all tubules. This is all renal medulla. Can't be the cortex, because if this was the cortex, you'd see the glomerulus, the slides we just saw of the glomerulus, or renal corpuscle. So this is an important term. The blood vessels that go along with the nephron loop are called vasa recta. So these are capillaries within the medulla, especially in juxtamedullary nephrons, right? Because those are the ones that go into the medulla. And here's the collecting ducts, which is the end of the nephron, going towards the minor calyx, or renal papilla first, and renal papilla duct to the minor calyx, major calyx. So vasa recta is the capillaries that surround the loop of Henle, or nephron loop. This is a cross section, so it's showing the thick collecting duct lumen, and you can see the nephron loop lumens. So you have a thick and thin part of the nephron loops. Okay, so this again is another collecting duct here. So the histology, which you have to go through, the microscopic anatomy, you have an animation, and you have to look at the histology in APR, Anatomy and Physiology Revealed. And look at this simple cuboidal epithelium, if you remember that, where the lumen is. So you should know the difference between the collecting duct, the thick and thin nephron loop, and the vasa recta. I wouldn't show you on this picture because it's hard to see. Vasa recta, this is a better picture of the vasa recta. And it's good because it shows it in red for the blood vessels. But look at the lumen in the collecting duct surrounded by that thick cuboidal epithelium up in here. So the histology, again, you'll do the lab, you'll see this, and you'll be responsible for the pictures on the practical. And I'll do a review before you start the practical, or maybe the first couple of days of the practical exam, right? So now this is urine structures. Remember the major, this is urine now. So the beginning is the major and minor calyces, then ureter, then urinary bladder, and the urethra. Okay, so this is about the urine, not about not filtrate anymore. Filtrate had a chance to be reabsorbed. This is the ureter, and the ureter has more muscular, just like the digestive system. Remember, it has the inner and outer smooth muscle layers, and the inner part on this view has that transitional epithelium because it stretches, right? And the bladder, you're going to see, is the same. The urinary bladder has the same histology. So is the ureter and the bladder. Remember, transitional epithelium from AP1, the only place we really asked you to know it was in a place like the bladder, urinary bladder of the uterus. Bladder just means a sac of fluid, or a cyst. A bladder is a cyst, basically. So the epithelium changes from low columnar to cuboidal to columnar. It depends on how much fluid is in the bladder, right? So this would be more ureter, and this would be more bladder here. And you'll see that in the animations and histologies. Again, just looking at the epithelium of the bladder. It's always the same layers, right? You have mucosa and submucosa and muscularis and the outer connective tissue, adventitia. Adventitia. And that'll continue into the ureter as well. So let me just, before we do, again, you could practice with this. You could see that the outermost is the renal capsule. So let's follow the flow. This is the renal cortex. So the renal cortex is where your renal corpuscles are, glomerulus and Bowman space. Here is, I guess we can call this the renal medulla, or just the pyramid, right? The pyramids are in the medulla. Right, and here it's pointing to the renal papilla, which have papillary ducts, which are extensions of the collecting tubules, or collecting ducts. Renal papilla, not sure how to spell that. And number 5 is the renal columns in between the pyramids. And this would really be the pyramid, I think. Remember, the pyramids have the nephron loops, or the loops of Henle, descending loop of Henle and ascending loop of Henle. Because remember, they're microscopic, right? So 7 would be a minor calyx. And 9 would be the major calyx. And 8 would be the renal pelvis, from what I could see. So now we're getting urine out, starting at the minor calyx, into the major calyx, into the renal pelvis, right? So 10 possibly could be the renal pelvis as well. So this is just urine, right? This is just urine. No more filtrate. And here is the ureter, which is the tube. Okay. So this is just showing, I guess, just part of the medulla, pyramid, and the cortex, all the way down to, basically to the renal papilla. So that's the parenchyma of the kidney, where the nephrons are. So I'll just say this is where the nephrons. Now you can't see them because they're microscopic. You just see the tissue. So remember, the renal corpuscle is in the cortex. The loops of Henle are in the pyramids or the medulla. And in lecture, you'll learn about concentrations of urea. Urea is a breakdown of protein. It's like a byproduct of breakdown of protein. High nitrogen, nitrogenous wastes like urea. But urea is used for concentrating urine. So again, we're not going into too much of that. Looks like you don't have a virtual lab on urine concentration. So again, before we finish this, I'll talk a little bit about that. Now, these are the blood flow, and you have to know this. We started talking about this before. So let's start from the beginning. So abdominal aorta, right? Or descending aorta, same thing, it's below the diaphragm, that you remember. oxygenated blood going to the renal artery. Then the large ones are the segmental artery. And then in between, along the renal columns, because the kidney has like 4 to 8 lobes or 5 to 8 lobes. So the next branch, smaller branch, is interlobar artery. And you can see that here and here. And then the one that goes along the top of the pyramid is called the arcuate artery. And then in between, going into the cortex, is the interlobular, because lobules are smaller than lobes. So this one is also known as the cortical radiate artery. I like saying interlobular, but cortical radiate kind of tells you where it is in the cortex going towards the glomerulus. Remember to put artery, right? Or A for artery, V for vein. So now the most important is the afferent arteriole, which is going into the glomerulus here. And then you have the glomerular capillaries. And then filtrate now, whatever is filtered out of the glomerulus will go into the PCT, and then into the descending loop of Henle, and then make a hairpin turn and go to the ascending loop of Henle, to the distal convoluted tubule, to the collecting duct. But this is blood. So this is where the red blood cells, like the erythrocytes and the plasma proteins, will stay in the glomerulus and continue into the exiting vessels. And the first vessel out of the glomerulus, this is blood now, is the efferent arteriole. Efferent arteriole, right, which will be coming right here into the vasa recta, which is along the loop, and it juxtamedullary. So the blood vessels here are vasa recta. So first place, though, after the efferent arteriole is around the tubules, which is peritubular capillaries. So the peritubular capillaries surround the DCT and the PCT in the cortex. But remember, the tubules will loop, so they need blood companion, and that's the vasa recta. So the vasa recta is involved with reabsorption in the loops of Henle, in the medulla. So the vasa recta is in the medulla. Let me just write that. And the peritubular capillaries are in the cortex. Because in the cortex is where you have your glomerulus, of course, renal corpuscle, and you have your DCT, distal convoluted tubule, and your proximal convoluted tubule. The vasa recta surrounds the loop of Henle, which is in the medulla. Descending loop of Henle, hairpin turn, ascending loop of Henle. Thick and thin parts of the ascending loop of Henle. And you'll find out the physiology, and I'll go over that if I can before we leave here. Now, the rest of the veins are basically companions, like interlobular or cortical radiate vein. Now, this is a companion vein. Then you have an arcuate vein companioned with the arcuate artery. Then interlobar vein companion with the interlobar artery, but there's no segmental vein. So that is not companion. There's a segmental artery, but there's no segmental vein. And then the blood goes into the renal vein and then out to the inferior vena cava to be returned to the right atrium to be back oxygenated and put back into systemic circulation after the pulmonary. So you know what capillaries are, you know the exchange, and this is pretty good here, up here showing you the afferent arteriole coming in, and filtration is happening in the glomerular capillaries, out of the glomerular capillaries, but what stays in is the blood cells and the plasma proteins, and then the filtrate that's in the Bowman space and PCT will be reabsorbed, and some things are secreted into the urine or into the filtrate. So again, in lecture, you'll know how aldosterone affects the kidney and the DCT to reabsorb sodium. Then you'll see how ADH, antidiuretic hormone, also known as vasopressin, will work on the collecting ducts to reabsorb water. Now I'm saying reabsorb, which means bring out of the lumen of the tubules, through the cells of the tubules, and into the ECF, and then into the blood. So anything that's reabsorbed or said to be reabsorbed is going back into the blood to elevate the blood levels or keep homeostasis in the levels of those solutes, like sodium, potassium, calcium, phosphate, glucose, amino acids, urea sometimes, and water. Okay, so here's good practice of the parts. Again, I think you're going to be pretty good with the gross anatomy, so practice your arterial and venous flow, right, from the renal artery to the afferent arterial and back out the efferent arterial to the renal vein. And here again, this is blood supply showing you the glomerulus, like number 3 is the glomerular capillaries. And you can see number 1 is the afferent arterial. It's a little tough to see. You probably have a better chance to go in MH Connect and using their practice areas. So you don't have to use these if you don't want to. Then the real anatomy, see what APR offers you as far as just pretty much gross anatomy. Of course, you know, you can see the kidney, you can see, remember where the adrenal gland is too. The adrenal gland is adjacent to the renal gland. That's why it's called adrenal gland, on top of the kidney. And it has no direct connection. You know, aldosterone is released from the adrenal gland, but goes all the way through the blood system to get back to the kidney distal convoluted tubule and collecting duct. So again, and renin, same thing. Renin is released from the kidney. So this is just showing the dissection of this retroperitoneal area, because you notice there's no intestines. There's no bladder here either, I don't think. And basically, hardly anything here, right? Just part of the bladder here. Okay. If that's helpful. It's a nice generalized look at the kidney as well. You can see the cortex and the capsule and the major and minor calyces, and the ureter is nice. So this is probably what you'll see in the atlas. These tubes, the ureters, left and right ureter, don't forget this, and the urinary bladder. Doesn't really show the urethra. Here's the pubic symphysis and the pubic bones, just anterior to the bladder. And it's different in the male and female, so you have to see the difference in the urethras in the male and female. Now, in the female, the uterus is on top of the bladder, right? So a pregnant uterus can really put a lot of pressure on that bladder. Transitional epithelium in the bladder. Like here's the male. Number 1 is the urinary bladder, and you can see how the urethra actually starts here in the male, right outside of the bladder. And then you have this prostate gland, which you remember from AP1, again, adding to the semen by adding citric acid, some other fluids. And you have the prostatic urethra. So an enlarged prostate, like benign prostatic hypertrophy, HBP, BPH, benign prostatic hypertrophy, can cause a problem with releasing urine. So you can have urgency to urinate, but you can't empty the bladder if this is enlarged. And there's an ejaculatory duct going through there that's reproductive, and then continues through the spongy urethra down out of the body. So again, this is the urethra is number 4. And over here you have, and you have glands too, like glands throughout this area. This is the ejaculatory duct here, number 8. And number 2 is the prostatic urethra. So again, and number 3 is called the membranous urethra. So there's 3 different parts of the urethra, but I'm not going to ask you that because you need to know the flow of urine. It doesn't show the ureter so well here, but I would say right here would be the ureter in this particular model. But you do the practice in your atlas, and it's really not that difficult. And this is the female. The genitalia is within the cavity. So you have the uterus is on top. And here's your urinary bladder, and this is the urethra, this is the vagina, and this is the anus. So again, just make sure you know the difference between male and female as far as the urinary tract, because you already did reproductive back in AP1. So this is probably more lecture. I won't, because it doesn't look like you're doing any real physiology or even in animations of glomerular filtration rate and glomerular pressure. So this is going to be lecture, but just to give you a heads up, Just a very general look at what's going on here. The afferent arteriole comes in ultimately from the left ventricle when you think about it. If you follow back the renal artery, you'll oxygenated blood, you'll go back to the left ventricle. So it comes in with a blood pressure, an arterial blood pressure, right? Because of course the arteries have thicker tunica medias and they bring in more blood in with more pressure. And generally that's called your hydrostatic pressure. So that has to do with what's coming in from and again, this is coming in though, it's coming in. So this comes in with pressure, right? And there are cuffs of muscle called sphincters around the afferent arteriole that control the diameter to how much blood flow goes into the glomerulus. Because the higher the pressure coming into the glomerulus, the higher the glomerular filtration rate will be. And that's too much being filtered out. So this is controlled autoregulation, neural and hormonal and humoral regulation to the diameter of the afferent arteriole. Because there's different pressures that are in the glomerulus, like osmotic pressure against, hydrostatic pressure against in the capsule, right? And osmotic pressure in the glomerulus. So you're gonna have to know about pressures and then what's going out into the PCT and also what's going out in the blood. There's a pressure, and this has control of diameter too, the efferent arteriole. So you have backflow or not in the corpuscles, or in the glomerulus, I should say. And there's cells you're going to learn that cover the glomerulus called podocytes and mesangial cells that control filtration, basically, how much fluid and solute is going to stay in the glomerulus or how much is going to come out into the filtrate. So you're going to know about glomerular filtration rate is the speed of the blood going in and out, and then you're going to know about the pressures that oppose each other. And this is why osmotic pressure is important and hydrostatic pressure is important as well, and how they oppose each other, and you get a net filtration pressure. So again, I'm not going to do this in lab at all, but in lecture, you're going to have to talk about net filtration pressure and glomerular filtration rate. And it has to do a lot to do with your blood pressure. And of course, there's millions of these things. So high blood pressure can really tax a kidney and cause kidney failure, or glucose, diabetes, too much glucose going into the glomerulus and not being reabsorbed in the PCT can cause a major problem for the kidney. It can become sclerotic and hard and ultimately destroy the kidney, where you need dialysis, which is a machine that helps filter your blood, or a kidney transplant if your kidney is failing, because this is extremely important to maintain the solutes in your blood and the water balance in your blood and body and cells. So this is excellent because this shows you, again, I probably won't ask you a lot of this, but what I may ask you is like what happens in the proximal convoluted tubule, PCT, which is 65% reabsorption of what? Amino acids, glucose, all your electrolytes, and water. Yeah, and also, there's many other things like hydrogen and bicarbonate as well. Descending loop of Henle is an area of water reabsorption. Now, I'm not talking about going into the filtrate, the reabsorption back into the ECF, then back into the blood. So you have to know your fluid compartments. The ascending loop of Henle, especially the thick part is impermeable to water. Which means you're not going to put water into the filtrate. You're going to keep it in the blood, in the cells. So this helps reabsorb water. The distal convoluted tubule is about sodium, potassium mainly, and that's where aldosterone works its magic by reabsorbing sodium, excreting or secreting potassium. And also you have your parathyroid hormone, which increases the reabsorption of calcium here as well in the DCT. Now there's some ADH works on the DCT, but mostly ADH, antidiuretic diuretic hormone, works on the collecting duct, the end of the nephron before it goes into the papillary duct, into the minor calyx. So this is the last chance of water reabsorption. This is where ADH really exerts its mastery. So when ADH is released from your posterior pituitary gland, it targets the collecting tubule, the collecting duct, to install these aquaporin tubes, which actually are passageways for water, and they increase the number when ADH is present. If ADH is not present, then your urine is going to be very diluted, too much water in your urine. And there's a condition called diabetes, has nothing to do with sugar, diabetes insipidus, which is no ADH. And you have a very dilute urine, like bedwetting, always urinating. So concentrated urine is what we want. You want to concentrate urine with your solutes and your nitrogenous wastes, especially hydrogen and urea and uric acid and creatinine. You want to get rid of that, right? So again, the urine should be concentrated. Of course, if you do an overnight sample, it should be concentrated. You should have all the amount of water back into your blood cells, into your cells and in the blood. So diabetes insipidus is no ADH, too dilute urine. So in lecture, you learn about concentrating urine versus diluting urine or not concentrating urine. So secretion, what's secreted? So in the PCT, you want to secrete hydrogen to keep your blood alkaline. So they have antiporters, and again, you'll learn that in lecture, that transport with sodium coming back into the blood, hydrogen going into the filtrate. And of course, drugs, you learn about that. Ammonia is a very high nitrogenous waste, right? That has to be brought out of the ECF into the tubules, out of the body, right? DCT with aldosterone, potassium, but there's also active transport with hydrogen. So hydrogen is involved in the DCT and the collecting duct and the PCT. So acidifying, this is about acid-base balance. So again, just to give you an idea of where it's going. So now this is abnormal. This is important. I like to ask these questions about what should not be in the urine, right? And one thing should not be in the urine is bilirubin, because that shows a problem with your liver, like hepatitis or cirrhosis. You shouldn't, like we told me before, you shouldn't have red blood cells or hemoglobin, right, in the urine, right? Glucose should never really be in the urine. It should never be in the urine. As much glucose is in your blood and the limited amount of reabsorption that you have at the PCT, you should never have that. So if you see urea, that means it's in the blood, like hematuria, glucosuria, glycosuria, hemoglobinuria. Ketones are a breakdown of fatty acids instead of using glucose. So people with diabetes can't reabsorb they can't get glucose into their cells. So they use fatty acids to make ATP, and then you get ketonuria, which is ketones. Infection will give you pus and white blood cells in the urine, and that's pus in the urine or white blood cells is called pyuria, and this could be a problem with a urinary tract infection. Nitrites are seen in infections as well. Nitrites are breakdown of bacteria, like when a white blood cell destroys a bacteria, like a neutrophil destroys the bacteria, a byproduct that you see in the urine is the nitrites. Nitrituria. And here's something you don't want to have is protein in the urine, like albumin. Sometimes they call it albuminuria. So these things should stay, all these things should stay normally in the blood. So glomerulonephritis, you learn in lecture, is a kidney infection. And like you have different infections, like, most bacteria come from outside, right? Especially from the colon. You have E. coli that normally lives in your digestive tube, especially your normal flora of your colon. But if it gets into the urethra, that's not a place where you want that. So you can have an infection of a UTI, like UTIs start in the urethra. So you can have a urethritis. which is infection or inflammation, which is an immune response, neutrophils, right, macrophages. Then if it goes into the bladder, bladder is a cyst, which is a sac of fluid. So an infection of the bladder is called cystitis. So if the bacteria continues up the urinary tract, it can go into the ureters, and you can have a ureteritis, inflammation, immune response to a bacteria, mostly neutrophils, PMNs, polymorphonuclear cells. And then if it continues up into the kidney, you can have what's called pyelonephritis. Pyelonephritis is a kidney infection. Kidney infection. And that's pretty severe if you have that happening in all your nephrons with excess release of PMNs like neutrophils. And then ultimately you can cause glomerulonephritis, which now you're on your way to a renal failure or acute renal failure. And ultimately that could lead to glomerular sclerosis. This actually could be one word. So again, this doesn't have to just come from an infection. This could come from other things like nephrotoxic drugs, right? Or trauma, or excessive hypertension, and also diabetes mellitus. Remember, diabetes mellitus is sugar, right? Because diabetes mellitus means sweet. Insipidus has nothing to do with sugar, glucose. So insipidus is bland urine, not sweet. Mellitus is sweet urine. So it's probably how they found out back 120 years ago. They probably had to taste the urine to see if it was sweet or bland, which is disgusting, but you know what? Limited resources. What can I say? All right. So again, go through your lab, see if you have to know this is specific gravity, seeing how much your urine is concentrated, which is what specific gravity does. And again, pH is important. The pH of urine should be here, 4.5 to 8.0. Specific gravity. This changes though because it depends on the temperature and everything. But generally, this is your normal range for specific gravity. So specific gravity is how much your urine is concentrated versus dilute. And the hydrometer tests that, which you saw on the page before. So the smell, right? Does it smell sweet? Does it smell like maple syrup? Is it amber, right? Light yellow to amber, which is normal. Is it relatively transparent, or you see particles in it? And then a dipstick test, you could test for glucose, protein, ketones, bilirubin, leukocytes, hemoglobin, right? You could test for all those, and nitrites as well in the urinalysis, which you take a dipstick and you look at the color change to see if any of those pathological findings are there. I mean, sometimes there is basically some bit of, like a tiny bit of trace of blood, especially during menstrual cycle or excessive exercise or trauma. There could be tiny bits of protein, but trace amounts. So I'm not going to go into the metabolic and respiratory acidosis, but you should know that the pH of blood should be 7.4. If it's 7.39, it's acidosis. If it's 7.41, it's alkalosis. So respiratory, but I'll tell you this, respiratory problems have to do with excess CO2, carbon dioxide. Metabolic have to do with bicarbonate ion. Just a heads up there. So this is the kidney, right? Bicarb, right? And here's the normal values. And here's the lungs. So these two organ systems work together to balance out to 7.4, right? 7.4 pH, or a range of 7.35 to 7.45 is an acceptable compensatory range. It's still out of 7.4 though. Right. So again, we're talking about pH of blood here, not pH of urine. pH of urine, like we saw, it could be 4.5 to 8. So that's got a high range, or a wide range. People who eat a lot of meat and acid products tend to have low pH blood. So the mean is around 6. Vegan diets high in vegetables and plant-based foods are generally alkaline. Okay. So again, this is just, again, we're not going to do this in lab. I'm not even sure if you have to do it in your lab, because there's no virtual lab. It would have been a good one, actually. But the problem is you're going to get so much of this in lecture that you don't need to do it in lab. So I guess the lab is pretty straightforward, just knowing the parts and knowing what I told you as far as filtration, reabsorption, secretion, and acid base balance, and the hormones. Again, but at lab I probably won't even ask you about ADH and aldosterone, even though it's fun to talk about.